So, hello everyone. Happy Friday. And it is my pleasure to introduce Elise Springer today. She is on the Return to Zero Hope Clinical Advisory Board. And I'm just going to introduce you to her first and then kind of let her take it from here. So Elise is a Los Angeles-based licensed marriage and family therapist. She's in private practice with a focus on perinatal mood and anxiety disorders, LGBTQ plus trauma, anxiety, OCD, and HIV/AIDS. So prior to private practice, Elise worked at a cross section of community mental health organizations. And she currently served as the co-chair of LA County's HIV Mental Health Task Force for several years. And for the last 7+ years, Elise has been teaching faculty at the LA-based Maternal Mental Health Now, as well as governing council member and governance subcommittee chair. So she's very involved in Maternal Mental Health Now, as well as PSI, and has been on the 2020 Mom Board, which is where I met her. And this is her area, and so she has a love of helping men through pregnancy, postpartum, and loss. And I'm excited just to bring this important topic of men and perinatal loss to clinicians who don't get a lot of training around this topic. And hopefully that through this, we can all better support parents who are going through a loss by understanding, the other side. We hear more about what women experience, but now we can hear a little bit about the male partner's experience. So I'm going to, Elise, can you see the poll results?
Let's see.
Or no?
I don't seem to be able to.
Okay, so I'll just read through them really quickly. Oh wait, I can share them. Hold on, I can share them. Maybe. Can you see them now?
Yes.
Yes, okay, great.
Great, okay. That is helpful to know. All right, everybody. So thank you so much for joining me today. I know obviously the world is kind of in a pretty chaotic place, and depending on where you are living, there are either fires and of course COVID, and the state of the world and the news cycle is pretty intense. So I truly appreciate you taking the time to attend this today. I do want to just, before we get started, say that the land that holds the space is the traditional territory of the Tongva in Los Angeles, and we acknowledge them and their elders, past and present. That's always something that I enjoy starting with. And just to clarify, I'm she, her, hers, and I think maybe Kylie has a little bit of an older bio. Right now, I'm a founding board member at California branch of PSI, and emeritus board member at MMHN and clinical advisor at 2020 Mom. Primarily in my practice, I use psychodynamic and CBT, and then I'm certified in IPT and EMDR, and I use actually quite a bit of IPT and EMDR with my father's in-laws. And, I would say, even though I do actually serve a lot of women in my practice, about half of my perinatal practice is cisgender dads. And part of the reason why I find working with dads so important is just basically on my own mistake. And I think it's just important sometimes, just as much as we want to share our clinical examples that are wins, it's important to share some of the ones where maybe it wasn't such a win and kind of sends you in a different path. And in 2005, I was working at what was then AIDS Project Los Angeles, and now it's APLA Health and Wellness. And I was running a pilot program for men who were homeless and had sort of a dual diagnosis, HIV and substance abuse. And there was a new dad who had sort of come in through the homeless services and had probably like a 3-month-old baby that he'd had with a female partner. And I had no training at that point in perinatal mental health, let alone men in perinatal health. And what I realize now is that that was sort of the way in which he was presenting. He was presenting in a pretty significant manic episode after a good chunk of years of sobriety. He had relapsed, and I just didn't see the connection. And so I was really, I don't know that I gave him the best health and help and support. Of course, we did get him stabilized over a longer period of time, but I really didn't understand like why this had happened. And I bring it up because it's a case that kind of sticks with me, only in the sense that it was just so protracted. The way in which he suffered was protracted. And I think if I had had this training about understanding dad who had had some perinatal mental health disorder, I would have better been able to treat him more quickly. And as we go along, I'll be sharing kind of case examples, because I think that that is so helpful when we're talking about dads. Let's see here. Let me make sure. So, again, we're just going to talk a little bit about differential diagnosis. I'll chat a little bit about hormonal, and then, even though it's not going to be quite as crystallized as 3 therapeutic techniques, again, I'll kind of take you a bit through some of the way in which I work with men. And then at the end, we'll leave a good chunk of time for questions, or even if you have cases, you want to sort of see how someone else or how I might have a perspective on them, we can do that. So if you've heard me talk before, or if not, I kind of have a real platform, which is that there's 3 U's of dads. And a lot of it is that they're under-screened. I mean, I don't know, we know in California we have mandated screening now for moms, but we don't have any screening or birthing parents, I should say, but we don't have any screening for dads that's mandated in any way. And I think, again, if we look across the broad section of new parents, dads just don't get screened. We know that in the US, we have probably about 10.4 to 14% of dads who do qualify for a perinatal mental health disorder, but those are the ones who are reporting. And it's hard to report on something that you don't know. So if dads or providers don't know sort of the symptoms of paternal depression or postnatal mood disorder for dads, it's not going to get reported. I will say that in other countries, the rates are actually much higher. And some of that is because they have a much better way of managing and recognizing dads in the postpartum period. I will say in England in particular, in India, both of those countries have very robust paternal mental health recognition and work quite a bit. So again, the reporting is a little bit higher. And then, again, just untreated. I think because so many of the organizations and frankly, even organizations that I am or have been a part of really don't focus on dads at all. They get left out. And, this is one of the reasons why I'm so appreciative of Return to Zero, because Kylie is really trying to make sure that we are including dads, and because we know that any sort of perinatal mood disorder impacts the whole family, right? It's not just one component of the system. So when we're thinking about why this happens, we know that there's probably some provider bias. And I think even in the name, this is something that I'm always trying to advocate, and I mess up all the time. I'll just say paternal depression. But if we think about with women, right, in the beginning, it was always postpartum depression. That was in the news. People got very scared. They thought that postpartum depression was psychosis, because a lot of the cases that made the news was psychosis. And we really know that there's just such a wide variety of perinatal mood and anxiety disorders. And then I think that's so obvious that it would be that way for dads too. And part of the difficulty, and one of the things that I would just encourage you to think about, is when we're looking at it, or when we're kind of saying maternal mental health mood disorders, would it be more helpful if we just had things a little bit less gendered, right? So of course I give a couple options here: paternal perinatal mental health disorders. I think that's what I use most often, but of course we could do paternal perinatal mood and anxieties. But what if we just said perinatal mood and anxiety disorders, which then kind of would cover all genders, including non-binary birthing parents? And, you know, I will say, of course, I live in Los Angeles, so I am seeing more birthing parents who do really identify as non-binary. But today I'm really going to be focusing on men and perinatal loss, which is why I didn't put fathers perinatal loss. And even though I will be using them interchangeably, I think it's just worth it expressing. Okay. So what's in a name? We've kind of talked about this, and I think with that first example I gave, you know, that was an example of someone who had not loss per se, but definitely some perinatal mood and anxiety disorder following following just birth of an infant. And we know it's like between 3 and 6 months is really where paternal perinatal mental health disorders would sort of flare. And when we're thinking about it in the context of loss, right? So whether it's miscarriage or stillbirth, we do know with women, of course, and even though providers don't always recognize, hey, you've had a miscarriage, you are going to have a mood disorder after, we really don't recognize it in men. So I end up seeing a lot of dads who come to my practice and like years later had no idea that if they had fertility issues or if there was some sort of traumatic loss, that they had any sort of mood disorder. So I'm going to just give some examples here. So for PTSD, this is a little bit easier to recognize in dads with loss, right? Because if you have a stillbirth or infant loss, we know that's probably going to get recognized. But I think with miscarriage too, it's important to recognize that dad is going to have loss. So as you know, sometimes with miscarriage, if baby is, for example, not a viable pregnancy, mom might be kind of given, hey, you know, here's a pill to do miscarriage at home, right? To kind of have a follow through with that. And there's not a lot of information about, there's going to be a lot of blood, there's going to be a lot of cramping, there might be some tissue. And I had a dad who came in following, it was sort of a later term miscarriage, right? Actually, I should say midterm, and had no information that there was going to be tissue as the result of this loss. And, you know, he was really trying hard to support his partner, really trying hard to support his wife. And, you know, they were in the late bathroom and cramping and a lot of distress, and she didn't really know what was going on, but he was very like impacted by the tissue. And just something to think about when we are talking about men in general, what access to education do they have about, for example, miscarriage? And I think with a stillbirth or an infant loss, if they're in the hospital, of course, there's a little bit more access to care and a little bit more of a wraparound of the whole family. But that's in the hospital. And then, of course, there's a lot of support after, but not so much for men. But I like to give that example for PTSD because I don't think people recognize like, hey, that can be a trauma equally for a male partner too. And fitting all the criteria, right? Avoidance of provider, sort of some avoidance of partner, frankly, some flashbacks, some acting out behavior, a lot of self-recrimination. So that would be a way that might show up. And of course, you know, irritability for men is something that really shows up in any paternal mood disorder, and not being able to recognize that partner, being so bereft by, here I am grieving this miscarriage and my partner's not grieving here with me, when the truth is in that scenario, there was just so much overwhelming trauma that there wasn't an ability to kind of be present. With PP, postpartum anxiety, I think that I'm going to give an example of one that has sort of a baby who, actually this was a full-term baby and no loss here for this particular example, but I like to, again, with that differentiation. So here was a dad in which baby had been born, baby was probably like 3 months, and dad had sort of the normal, not normal, what we see in anxiety in general, some checking behavior, right? Which just kind of got written off for, new dad. We do that with moms too. Oh, you're going in, you're putting your finger on baby's nose. This, of course, we know happens so much in pregnancy after loss or baby after loss. And so this was happening for dad, but the anxiety really globalized to partner. So if his partner was like too long silent, like if he was at work and hadn't heard, like there would be some real panic and anxiety, and it kind of grew into a panic disorder, in that he really couldn't go to work because when he was there, he was just so terrified that mom and baby, something bad was going to happen. And I think especially right now in the world, because things are so chaotic, it would be easily dismissed that this would just be generalized anxiety, unless you kind of assess for, look, here's this new baby. And just speaking in terms of anxiety after, we know in pregnancy after loss, there is going to be a tremendous amount of anxiety, and it's going to show up in a lot of different ways. And I think, mostly what I find is that there's a lot of like postpartum OCD. So even if it's someone who doesn't have a prior history of OCD, there might be a lot of vulnerability in pregnancy after loss for that postpartum OCD. And again, it's like, what happened in the hospital? What's their narrative? Was it miscarriage, stillbirth, infant loss? And then, of course, have we gotten past with this new pregnancy? Have we gotten past with this new baby, past all of those points in which there was loss? And up until then, of course, the anxiety is really intense. So that checking behavior is really robust, and the intrusive thoughts are very robust. And I think, again, we do a disservice with dads when we don't kind of assess them, because there's a stoicism, I think, for men who are of childbearing age right now, that, not recognizing intrusive thoughts as being something with OCD, like the same thing as with women, horrible accidents happening to baby. One case I had was dad, pretty much refused to let baby out of the house, and not because of anything other than there'd been a prior loss, and there was just so much intrusive thoughts happening about a car accident. All right, let's see. So I think I had mentioned my 2005 case, but I want to give another example of postpartum bipolar diagnosis. And, we know for women, right, that a manic or psychotic episode in women is often a sign of postpartum bipolar disorder. And I just presented on this in PSI, so I won't belabor it too much about postpartum or paternal psychosis, but I think this happens with dad, truly. So in this particular case, dad had, there was a non-viable pregnancy. There was termination around, this was just about at 20 weeks. And mom was in treatment and had support, and no support for dad. So I found his way to me. I didn't even know that they in his family had a loss, like, because, to be fair, sometimes, like I'm saying, we have to really do this assessment for loss for perinatal mental health. And it took a couple of sessions for me to really get to, in this history, you're coming in. He didn't realize that he was coming in because he had this loss, right? It was just like irritable, depression, anxiety. And it was about 4 months after this termination that he started exhibiting symptoms. And there was a pretty significant psychotic break in that dad had been working for a company, and without getting into too many details, it was a company that had a lot of proprietary information. So there was a lot of paranoia and anxiety that started to manifest. And in the beginning, truly, I thought that this was just really true to his work, and frankly could have been. But as it went on, there was some of the other classical components, right? So there was some suspicion of his wife, some suspicion of his partner, and an increase in substance use. And the break happened in that he pretty much was having a very public manic episode and accusing wife and partner of conspiring against him. I mean, this is a client who ended up going to treatment and escaped the treatment center. So one, because he was very high functioning otherwise and had no history of any sort of mental health issues, and was able to kind of use his verbal ability and intelligence to pretty much talk his way out of the rehab, and he did escape from the rehab and continued with the sort of very florid manic episode. And he was able to get treatment, but we don't even think about this in terms of differential diagnosis when we're thinking of men. We're not thinking like, oh, 4 to 6 months after a loss, there might be some sort of perinatal mood and anxiety disorder. Whereas if I had sort of flipped the genders on that and said, hey, this was a mom who 4 to 6 months after having a termination started to exhibit this, we might say, wow, that's kind of a long time. But also, you know, she was pregnant for 20 weeks, so that makes total sense. And then again, you know, this can also be, I think I put up this following early stillbirth because this was another case that I had, but rather than going into that one, maybe I'll talk about that one a little bit later. But I wanted to just remind you that it's the waxing and the waning that can be in that psychotic episode. And there's a lot of depersonalization that happens. And, you know, again, how do you really ensure that when you have a dad who comes into your office, you know, and it's that first full year postpartum, you are looking at it with the same sort of critical eye that you might with mom. So I would like to talk about hormonal research just in the sense that I think we don't really assume that dads have a hormonal interplay when their partner is pregnant. But we do know, again, that there is something to dads living with mom, right? And someone at some point, and I can't remember who to attribute this to, sort of made the mention of like, look, when everyone's in a household, we know that we all share the same sort of gut flora, right? We all sort of have the same sort of biological flora in our system. And some of this is that when dads and you know, when men and women are living together and there's sort of a real hormonal flux for mom, there is an impact on dad. So I've put up some of this research here and I'll go through it very quickly. You know, we know that there's an increase in estrogen prior to delivery for dads. So if mom goes to term, and again, this is important for your clients who have had either stillbirth or infant loss, we know that there's a real increase in estrogen prior to delivery, and then also a drop in testosterone. And what happens when there's an increase in estrogen? We know that in general, that puts us all at risk for depression. So now you have a drop of testosterone and you have an increase in estrogen, so there's some vulnerability there for depression. We know that for dads who have lower testosterone, they may have higher empathy, but some of that is a significant interplay with crying. So if you have a dad who is in a pregnancy after loss kind of scenario and is sort of trying to engage with baby, there is going to potentially be some lower testosterone, but the crying may impact that in some way. Interestingly enough, again, this is why all this research is like, we always need more. When there's higher testosterone, right, and there's not really a predictor right now of who is going to have lower testosterone and who's going to have higher. That I don't think I know of a study right now who has kind of been able to determine that. And as always, if you have information, I encourage you to share with us, maybe even in the chat box. But with higher testosterone, there might be a better provider. On the other hand, meaning, right, so more financial stability, more ability to create sort of an umbrella for partner and baby. But when there's a mid-range testosterone, not too high, not too low, that's when there's better health and better energy. So again, wouldn't it be interesting to find out, like, how might we predict this? Is there a way to predict this? When dads go to work, they have higher testosterone. When they are home with baby, they have lower testosterone. But when there is conflict at home, so again, if you have pregnancy after loss, whether there's babies maybe fussy, maybe mom was anxious during pregnancy after loss, which we know, of course, is something that happens. So if then we know that there is some sort of correlation between anxiety during pregnancy with babies who have a little bit more fussiness, and if there is that kind of potential conflict, then dads will have some sort of fluctuation in their hormones. And again, this is why I think it's just so important for us to be looking at perinatal mental health in the whole picture rather than siloing it out. Because of course, we know when dad is a little bit more steady, there's going to be better parenting. So just some more research here. Again, I think it's always helpful to have this and just be thinking about it. So a kind of more recent study found that when you measure cortisol and testosterone before and after holding baby, the cortisol lowers, and that sort of again increases responsiveness. But if there is a higher cortisol, that meant that later on there would be more childcare involvement. So do you need to memorize this? No, but is it important to kind of think about, okay, what is happening? And then what does this mean for your clients who have a stillbirth in hospital, right? Because this is when we're talking about this research, we're talking about it in the context of babies who go on to kind of live. So we don't know what that means for a dad who does have the opportunity in the hospital to hold a baby or to engage in a really positive experience during stillbirth, or even moving through to infant loss later. So is there a drop off at all? And if there is a drop off at all in those scenarios, what might that mean for triggering either a rebound increase in estrogen, or what might that mean for having it be so fluctuated that it might trigger a perinatal mood and anxiety disorder? And I wish I could tell you the answer, but I really do just like to ponder these questions, and I encourage you to as well. So when we do have blunted cortisol, there's unfavorable paternal parenting. And I look at this and I included it because I find it interesting in the sense of, when we see people in our office, are we kind of determining what their adverse child experiences are? And is there some potential to have had such exposure to trauma that there would be a blunted cortisol response just in general prior to any sort of pregnancy? And I think, again, I don't have an answer, but it is something that I kind of assess for, always doing the ACE when I am seeing any parents, and I'm sure many of you do too, but it goes out in my intake. And I kind of try to assess, like, hey, when you've had pretty significant traumas in your past, or when you've been in crisis, what do you react? How do you react? And it just gives me a tiny little clue. It's not a whole picture, but it gives me a tiny little clue as to what might happen, particularly in pregnancy after loss. Oxytocin is incredibly important in parenting. We know that there's a pretty significant interplay. So again, here's where we just kind of have to think about, what does that mean? And there's just not going to be a way, of course, that you're going to be able to determine like a high oxytocin. But we do know that if there is something that can bring up the oxytocin, like when mom has her oxytocin flush and birth, or birthing parent has an oxytocin flush, does that impact dad? We don't quite know yet. But if that is the case, if there is an increase in oxytocin, then we know that there's sort of increased sort of playfulness. This last study, this Ling study, is interesting because they experimented with nasal oxytocin. And they did this by both measuring the levels of oxytocin prior to birth and then gave them sort of a treatment of nasal oxytocin. And they did find that it improved paternal motivation. So all this again to say that there is some real hormonal components going on for dad that we don't necessarily know how to synthesize into our work. And, you know, I think just in terms of thinking of even my referral network for reproductive psychiatry, you know, when I have a dad with loss, I just send him to a general psychiatrist, not necessarily a reproductive psychiatrist. But we're finding, you know, as the research continues, that this is something to really not take lightly, that there is just such a significant interplay with dads and men during pregnancy, and then that means also with loss. So some of this, again, maybe if you've had some training in paternal mental health, you might know on some of this, but this is a really fascinating study. And I bring it up again a lot because of pregnancy after loss. When children whose dads had high levels of psychological distress ended up having higher levels of emotional and behavioral problems. So again, there was a correlation with 2-month-old crying with prenatal depression in men. And again, when we're talking about dads and pregnancy after loss, you know, what happens there? Obviously, we know there's usually a pretty significant psychological distress, so to speak, in loss. So if that carries over through a subsequent pregnancy, which is often the case because there's this anxiety, there's this distress, I'll talk about that in a little bit, but there would most likely then be an increasing correlation. And then if we go back, what does that mean for dad and hormonal components, right? We know that there's an increase in testosterone if there is some distress or conflict with baby at home. So is there something here to just kind of keep an eye on? And the answer is absolutely. We know that there's some correlation for paternal postnatal depression at 3.5 and 7 years old. You know, with girls, there's an increase in hitting in the 3-year-old range. And then particularly for boys, there's more correlation to oppositional defiant disorder in the sort of 6 to 7 range. So, you know, paternal depression, prenatal paternal depression, using that term, is really important to screen for and treat because, again, it impacts the whole family. Again, I think I just sort of mentioned this, increased conduct behavior in boys. And I do want to kind of say, we always think about men, especially in the US, in the context of partners, right? So if mom has depression, we know that 50% of their partners will have depression too in that perinatal period. But I think it's important to think about, again, look, dads are going to have real sort of psychological distress, so to speak, paternal mental health disorders, even without having a partner having depression. And I do see this. I do see sometimes, and again, because I end up getting a lot of my referrals through either nurses or doulas, that's when dads kind of make their way to me. And usually that's because mom has self-reported some behavior in their partner that then sort of there's a suggestion of like, oh, maybe he needs to kind of see someone. And that's how I end up getting a lot of my referrals. And mom may be okay, but dad is not. So we know though for loss, there's kind of a real difference there sometimes that, again, we think of moms following loss is really having an increased distress. And I would argue that even though the self-report for dad is that there's a little bit less in terms of a longer term impact, I don't always see that. I really don't. I see dads who come in and have a lot of complex feelings about loss longer term, right? So it absolutely impacts if there is another pregnancy after loss. Okay, I think I talked about this. Did I do this one? Okay, yeah. So this study, again, if you're looking at some of these studies and you're looking at some of these really big studies, you're noticing that they're not happening in the US. And again, I think there's just some going back to both provider bias and just our attitudes around men in pregnancy in some of the organizations that do serve that sort of mom-baby dyad. But this MOBA study was really, it's a pretty significant study. And again, we know, here we go, that it is, I'm sorry, hitting behavior at age 5. So I said 3 earlier, I apologize. But how can we sort of take this information and advocate for dads in our systems? And then again, when there's loss, how do we make sure that dad is getting the support too? And not just sort of in that immediate, either the hospital or immediate period, right? Because we do have more of a robust system for moms after loss, but how do we make sure to have that for dads too? Okay, so I think in terms of stillbirth, you know, I think that there's a lot of avoidance and coping behaviors that we might recognize from paternal depression, but that there would be increase in work, goal-directed behavior. You know, I think that this happens for moms as well, but there is a real conflict of identity, right? Because when you have a stillbirth, you are a father regardless of loss. And how do you reconcile that, right? Because just as we have matrescence, there is also patriescence. And really engaging with dads in a way that helps them understand, even though there has been a death of baby, they are still a father. And we know, of course, for dads with loss, there's a lot of grief suppression, particularly in those early moments. There's a lot of outward facing role, both in the household and even in interacting with providers. And I think dads really do feel diminished by that lack of reflection, both in sort of an acknowledgement in whatever their social support system is and in the provider circles. And you know, again, some of the unique characteristics we know for families that have experienced either stillbirth or infant loss, you know, and even miscarriage, that there's not just the loss of the baby, the infant, the life with baby and infant, the life as a sort of family in the here and now. There's a real loss of the social support system. And I think men have sort of traditionally, we think of it as men having smaller social support systems than women as they get older. But to then kind of have, as we know, in you know, pregnancy, infant, stillbirth loss, that there's just this real distancing of the community. And so much of that can be, who is this community? Do they have anxiety? Do they have distress over what that means if people have been sort of pregnant together and bonding over that? There's this real anxiety. We know that that happens for social support systems. Again, that distancing goes on. And so now here dad is, he is both trying to navigate and suppress his grief, but really be the outward facing person and making sure household continues to run, responding to people checking in. And I think that there just really hasn't been a place to reflect that there's a lot going on for dad too, and then how that might impact the family system as a whole. And I think sometimes when I talk about men and perinatal mental health, I'm met with like, look, you know, we haven't even gotten there with women, and you know, why are we talking about men? And pardon my soapbox, but I think truly, I'm going to say this a bunch of times, I think it's just perinatal mental health. It impacts everybody. And I know that my own sort of belief of this comes from having worked in the HIV and AIDS world for so long. You know, for those of you who may or may not remember, in the early days of HIV and AIDS, it was called GRID, gay-related immunodeficiency disorder. And so there wasn't this focus of like, oh yeah, this is something that can impact everybody. And you know, this is sort of how I think about it, just in terms of the policy and advocacy piece. You know, not that the correlation is about sickness. It's really about how can we really silo something out when it is impacting everybody. And if dad is sort of in this place where he is kind of relentlessly being the person who has to interact with the whole system, what sort of emotional toll does that take? And how might that even impact the relationship subsequently, right? Is there a burnout? Is that lack of reflection really something that creates this desire to kind of be effective or efficient, or not even acknowledging the loss because there's just been so much of it that has been avoided up till now just to cope? So again, I think this India study on stillbirth is really interesting, and I don't know how it might relate in the US, and I always find it a little bit confusing. But of course, I like to give as much data as I can. So they kind of did quantitative data, right? So this was not just like anecdotal stories. This was quantitative data that showed that men who had a history of stillbirth had increase in anxiety and depression. They definitely had perceived less social support. So we know that that is something that is very similar to here in the US. They had more egalitarian views towards women than men without stillbirth. So again, I don't know how that might correlate here in the US. But then at the same time, fathers of stillbirths were more likely to be emotionally or physically abusive in their families. So that is kind of interesting. And I don't have a good answer as to why. And I think I would have included it if that study, I don't know, had the answer as to why. But I like to theorize. And again, theorizing that when you are in a situation where you really have to avoid or suppress or be the sort of relentless person kind of navigating the whole community, is there a possibility that some of that feeling or intensity gets sublimated and then really comes out in this emotionally or physically abusive kind of way? I think when we're talking about loss, it's important to talk about men and infertility. And I would say that there's a lot of feelings about sex and gender. And, this has happened where I see clients, men in particular, who have, trying to get pregnant, and mom gets tested, right? And what happens all the time is like, again, I don't know if you guys see this in your practice or not, but mom goes to the fertility specialist or the doctor and gets tested, and everything looks fine. And they're told, you know what, you just have to keep trying. And it can often take a really long time for discovery that there may be men who have some infertility issues. And of course, we know that infertility issues for men are on the rise, and there's a whole wide reason why that might happen. But depending on what your client base is, who you are working with, this may or may not get attended to, right? So if you have a dad who does end up getting screened for some infertility issues, but they don't have the financial resources to kind of do any sort of IUI or IUF or anything, or IVF, sorry, then there's a different sort of treatment plan than if you have clients of means who are sort of pursuing some of those more incredibly expensive dynamics. And I think working with that core schema around something wrong with me is kind of, again, something that isn't recognized so much in terms of loss, like looking at infertility in men or genetic disorders in men as loss. And then, of course, if you're working with fertility clients at all, you know that there's been an increase in sort of testing, including microarrays, right? So if you are familiar with the microarray, that more or less is like, here we are testing for a genetic disorder. And to simplify it, you are given a red, yellow, or a green light. And I think that that is incredibly tense and intense. And I had a client at one point who, this is the story, right? So mom was getting tested, everything was okay with mom. And it took a really long time and a switch in a bunch of providers for them to say, hey, you know what, let's bring dad in. And he got tested. He did find out that there was some some genetic dynamics along with sort of a very low sperm count, and, was given sort of like, here's how you're going to navigate this. They didn't have the means to kind of do anything sort of in terms of IVF or anything like that. So they did manage to get pregnant. There was kind of a percentage that they had been given that, hey, this may happen. You are going to need some further testing. And when they they ended up getting their 13-week scan, right, and the NT, and they found some other sort of genetic dynamics. But the provider's like, you know what, I think this is going to be okay, and we'll wait for the sort of 20-week scan. And at the 20-week scan, between the 13 and the 20, they did the microarray, and they were given a yellow. So here we are in this real quandary, which is like, when you were given a yellow and a microarray, do we know if baby is incompatible with life? Don't know. Do you know if there's definitively going to be something wrong? We don't know, right? Because it's a yellow, not a red and not a green. And I think this causes an immense amount of distress in terms of, it's my fault. I did something wrong. If it wasn't for me, my partner would have a healthy baby, and what are we going to do? We don't have the means to provide for a child who might have some pretty intense distress. We don't know if we have the psychological stamina to navigate, baby sort of maybe living just a few hours after birth. And again, just so much of a lack of community. Just no resources, lack of community. And they did ultimately decide to terminate. That was the best choice for them, as they continued to kind of speak with the genetic counselors. But this is a real example of another kind of loss that just does not get spoken of. And I think it's important to acknowledge. Oh, okay. So I think I talked about this a little bit. I think in terms of miscarriage, I think it's important to kind of think about, like, where does religion play a role for your clients? And that's always something that I kind of do have to assess for and ask, because sometimes there is that manifestation of, like, people saying, hey, God's going to give you the baby that you're supposed to have, and you weren't supposed to have this baby. And depending on their level of religion, that can be something maybe they get comfort in, but we know how damaging that can be when, it's sort of attributed to the universe and no acknowledgement of grief and loss happens. So I think that depending on who your client is, maybe they have relief or ambivalence. Maybe it will be sort of more grief and loss. And I think if it's depending on wanted or unwanted pregnancy, and I think, to give the case example, I had a dad who, him and his partner had high levels of infertility, and they kept having loss after loss after loss, right? So I think this was probably about 6 years of loss, which is a really long time. And again, no means to kind of do IUI or IVF or anything. So there was just trying, she would get pregnant. There was no real good explanation. This wasn't a case in which they had a diagnosed fertility issue or any sort of like known reason. And this was exhausting. This dad said, this is exhausting. This has been 6 years and it's exhausting, and just kind of so numb to like the continued loss of ongoing miscarriage. And, there was kind of this discussion in this couple of like, look, this is the last time we're going to try. And this dad, kind of came in and said, after they had yet what was going to be their final miscarriage, they said no more after 6 years. He said, look, I have a lot of both relief and ambivalence, right? I'm really sad about what this means, and because this was very important to us, but I am so relieved that we do not have to go through this anymore, because it is so fraught with anxiety and distress and the waiting. Is this going to be a pregnancy that continues, or is this going to be a pregnancy that is going to have another loss? And then we have to like deal with our whole community again over and over and over again. So there was a real exhaustion there. And I think that is something to kind of just, again, acknowledge that there can be mixed feelings around it. Again, in terms of like abortion, looking at like to what degree is this sort of helpful for this client or not. I had a client at one point who did have a pretty known incompatible with life pregnancy, and both mom and dad came from highly religious backgrounds, and they, in their relationship, it was very much like traditionally mom kind of had said, what, I'm going to have this baby no matter what. And as time went on and they realized, yes, this incompatibility with life is going to mean either a stillbirth by the time we get to the third trimester, or, moving through the stillbirth at the end of the third trimester, or infant loss. I think he was like trying to give her space, and we had to work with like, how can you articulate that you do have a preference here, that even though there is this sort of like religious background and religious upbringing, you really do feel like you would prefer to kind of engage in this termination now. And I think what so much of the guilt was, once he did speak to his partner and she actually had shifted her view and was in agreement, they had decided that they were going to terminate the pregnancy. But it was so much the anxiety and depression subsequent to that termination was how to speak to parents about it, how to speak to the community about it, how to say that it was a miscarriage rather than an abortion. And again, that's because religion was very sort of important in their social support system. And then subsequently, there was a lot of what if, right? And I think that that is something that can happen when it is a dynamic like this particular instance. Was that the only chance? Was that the only chance we were going to have? And then there was a guilt and stress and anxiety. And again, that was so much tied into their sort of religious background. So, again, when we're talking about infant or child loss, we know there's going to be significant PTSD. And I think so much of that is, where are you birthing in the hospital? Is there knowledge of birth loss? Is there knowledge ahead of time, right, that this is going to be something that's happened, or is this unexpected? And was there an opportunity for grief and caring? Was there an opportunity to hold baby, to name baby, to have pictures of baby, to get handprints and footprints of baby? I think so much of that can really, we know, assuage some of the subsequent grief and loss, but some of that can also become part of the PTSD, right? And for one dad that I had, there was so much like, he had been holding baby when baby started to shift from sort of a little bit more pink to being not as pink. And I think that was the moment for him when we were talking about the trauma. It wasn't the birth and it wasn't sort of the loss, because he had sort of been able to make room for that. But it was so much that moment was the moment that was the trauma for him. And even though he had felt like he had bonded, there was something about that moment for him that made him feel like he had done something wrong. And that was where we ended up doing a lot of the work. Again, this what if really comes up with men, infant, and child loss too, right? In the same way that it might for all birthing parents. What if that was the only chance? And then there's the guilt and the stress and the anxiety about it. I think the pregnancy after loss piece too, how will I love this next child? That was a pretty significant, this is something that I also do see in pregnancy after loss, which is, I have this son. This is my first son. My son is this first child, and my first child, died. How can I possibly love this next child in the same way? And there's a lot of sort of distress over, how can I be, a father? In this one case I'm thinking of right now, his first was a son, and the second subsequent child was a son. And so the sort of way in which he was going to navigate the world, how could he decide what was going to be best for him when he met people in the world and they said, oh, is this your oldest son? Right? So how that was like a lot of where his trauma was, that every time he knew he would get that question, that he could sort of feel that there would be trauma around that. And what was the answer going to be? Would he disclose? Would he not disclose? So would he kind of feel differently about this subsequent child? So there was a lot of work there that we had to focus on. So we know that just like for women, there's psychosocial risk factors in terms of the way in which loss might lead to sort of a paternal perinatal mood and anxiety disorder. So what was the loss previously? I think I gave you the example of the couple who had tried sort of for 6 years and just had what dad used the word relentless. He used relentless miscarriages. And, there's a lot of like, why does this keep happening? And it's both existential and practical. And then it's like, just again, relentless is the word that he kept using over and over and over again. Parenting distress, you know, I didn't even get to be a parent. Now that's obviously something in terms of like a social, a psychosocial dynamic that might sort of increase, especially if you're in a peer group in which you are sort of watching or witnessing people move through those stages of child rearing that you didn't have that opportunity to have. So this definitely is something that needs to be attended to. Decreased marital adjustment, again, she thinks it's my fault. Like, I think that this goes both ways. I think this is a common dynamic in couples that have experienced loss, but in those early days, right, if there's no sort of discussion about it. But when I'm working with dad, there's often not an acknowledgement of that this is how he is feeling to partner. And, you know, I think there's so much guilt that we know happens in loss, but how do you help a dad who's so used to being this forward-facing person who is really subjugating all of that grief? How do you help him articulate what is going to be a pretty significant amount of guilt? Right? Low parenting efficacy. I couldn't even make a baby, let alone take care of it. And these are obviously some quotes from people that I've worked with in practice. And then, you know, the quality of the marital relationship, we're not meant to be together. And so much of that comes in with the self-recrimination and the guilt that I started referencing earlier. And then what is going to, for anybody who's experienced loss, really exacerbate that loss? And it's going to be a lack of support and community and lack of relationships with you know, an opportunity to really put those big feelings. And again, this is probably, this last one is why I find IPT, interpersonal therapy, to be really helpful in working with perinatal loss, because it's navigating those social support systems in a way where there is an opportunity to feel held by community. Okay, let's see. So again, just as we know with birthing parents, there's a history of mental health concerns. Of course, it's going to exacerbate any potential for a paternal mood anxiety disorder following loss. Again, then there's managing the anxiety for subsequent pregnancies, fear of watching partners suffer again, and fear of loss of sexuality and intimacy, because we do know, obviously, after loss, there's a real perinatal loss, there's a real loss of sexuality and intimacy in relationships, particularly in those early days. And I think that for men in particular, there's the sort of, how can I possibly approach my partner again when this is what has happened previously? And I've seen that a bunch in my clients, when mom or birthing partner sort of like, okay, I want to try again, that there's a real fear and anxiety around intimacy, but then the loss of like, well, what will this mean? How, I don't know if I can go through this again. We know trauma begets trauma. So again, having that ACE score, and of course goes to the nursery. Here's something that I find so fascinating. And of course, this is with loss or without loss, but if there is an overprotective family of origin, there's an increase in paternal peripartum depression. So I find this fascinating because if you are doing any sort of genogram with your family, and any sort of genogram with a dad who has loss, you know, in their history, like, did their family suffer any loss? And I've had a couple of cases in which I'm seeing a dad who's had loss, but their parents also had a loss in the family, and that subsequently created a real intense anxiety. I've also had clients in which they have maybe not grown up in the US or sort of had some real trauma, and you know, had to come to the US for asylum in some way. And as a result of that, their family of origin has been very overprotective. And again, that would increase the risk of dad's paternal peripartum depression. So that's with or without loss. And it's just really interesting when you think again about how trauma begets trauma. So in your loss clients in general, if there is a real anxiety for pregnancy after loss, which again, we know happens, how then does that carry on to any potential subsequent generations, right? Which is interesting to kind of contemplate. I find psychoeducation in this can just be useful, just talking to dad about how this is a possibility. So, you know, again, illness risk factors, the loss around anxiety. I'm sad I even have to be sad. We just know, how are we going to sort of navigate that fear and anxiety about the partner and gestational parents? Hypervigilance, that's a real kind of subsequent dynamic that happens, and hypervigilance even without a subsequent pregnancy. And then again, you know, that trigger of pre-existing condition and unidentified. And I think in the case example that I sort of fumbled through a little bit about the dad who had the sort of manic episode, you know, no history of any sort of mental illness. However, subsequently, truly that manic episode did really lead to a bipolar 1 diagnosis. And, you know, this is just something to be aware of. And when there is that sort of pre-existing condition that was unidentified, then we know that there is an increase in marital dissatisfaction. One, because there's the like, well, you're not, you know, the man that you were before loss, right? Which is something that I've worked with couples sort of in my office saying. And similarly, when the depression is really significant, it does globalize to marital dissatisfaction too. So just to repeat myself, so I'm a broken record a little bit, this is why it's just so important to look at perinatal mental health in the whole system. So we know, again, another risk factor, expectations of fatherhood, sole financial responsibility, increase in pressure for promotion work. And when you have a dad who's sort of managing their trauma or their depression by sort of engaging in that intense work, it just, again, can be another risk factor. There's also sort of that you have to go on as life is normal, because now you have limited leave, right? We don't have great leave. And how are you going to be sort of making room for loss, helping sort of partner manage through loss, being that outward facing person, and then of course navigating all those responsibilities? And what if there's other caretaking? What if there's other children in the house? So sometimes there's a pretty significant sort of gender, you know, role reversal that might happen in a cisgendered couple who's had a loss, because there might be equal or more caretaking for other family members, other kids, you know, if mom is sort of really incapacitated by loss in some way. And then again, you know, this sort of do it all perception that dad kind of has, like, no, I got this, I can do this, I can white knuckle through this, like, you know, I'm having a hard time, but you know, my partner's having a harder time, and I'm just gonna kind of muscle through. But meanwhile, it kind of comes out in that irritability and distress. And it makes me think again about that study from India on stillbirth, in which there was an increase in emotional and physical abuse following stillbirth. So does that globalize to other losses? I don't know. So, you know, when we're working with dads, there's usually 5 themes. And I think that this isn't necessarily so particular to dads, but living with uncertainty, coping with uncertainty, relationship with the next child, you know, the continuing grief process, what it means to be a parent, and then what kind of masculine traits happen. Like that these are something, you know, what roles are you now taking on that maybe you wouldn't have before loss? So just again, thinking about this in terms of grief and loss. And I know I'm kind of zooming through a little bit, but I at least want to give some time at the end for any questions that we have. So, you know, psychoeducation, EMDR, dyadic work. I work a lot with perinatal pregnancy after loss. I usually do encourage dad to bring in new baby, and we do a little bit of dyadic work. The harm reduction, CBT. So, you know, all these things, it's sort of like, what is in your grab bag? So for me in particular, psychoeducation is always where I start. Absolutely. Just the psychoeducation about like, here's what to expect, here's what's happening, you know, and that is part of what the IPT model is. So if you're familiar with interpersonal therapy at all, in the beginning of interpersonal therapy, you do tell your client what their diagnosis is, and then you sort of talk through that. And that is something that I will name for dads, for men who sometimes don't know what is happening, right? They know maybe they're coming in for irritability or a partner dynamic. Maybe they have access to know that they are having a perinatal mood and anxiety disorder. More often than not, they are aware that they've had loss and that it will have had some impact, but I get very specific. And I think that that helps to, again, sort of that whole name it to tame it, sort of neurobiology concept from Dan Siegel. In EMDR, which of course is so useful for PTSD, but the adaptive information processing is also something. So even if you are not trained in EMDR, it's just sort of a systematic way of getting people to think about, like, hey, when else have you felt this way? Which we know is something that happens in psychodynamic therapy too. So you're feeling an immense amount of grief and loss. You know, is this something that you have experienced before? Tell me a little bit about that, so I at least have a context. And sometimes that can unhook it, which is what we're doing in EMDR. We're always trying to think about, how did this grief and loss, how did this trauma moment really hook onto a pre-existing system? And how do we sort of process through that so it's no longer really having the same charge that it does? And I'm always honest with clients. Look, there is nothing I can do or say that is going to take away this loss. And they know that. And of course, it's just words. But there's something about, it's not necessarily going to get better. It's going to get different, right? You probably do this already with all of your loss clients. But dads don't necessarily hear that anywhere. There isn't that messaging for them. And, you know, if they are kind of engaged in treatment, where there's them as a couple, whether it's sort of grief support groups, what I have found is that even in those sort of more grief support groups, most of the information is really geared towards mom. And so dad may not necessarily take it in. That's what I mean by that. Harm reduction, again, that's just around some of the maladaptive behaviors, whether that's increased workaholism, whether that's substance use, whether that's sort of like engaging in sort of an emotional affair, which I find to be sort of a common paternal depression dynamic, right? Not always, but definitely that sort of, I'm not able to get or want to bother my partner at home. So where am I going to get those emotional needs met when I'm not so attuned to what's happening? So much of the CBT that I do with dads in this way is schemas for loss. So going back to those themes before, like, what does this mean? How are you navigating that? There's something wrong with me. I did something wrong. I'm not safe. The world is not safe. I cannot keep my partner safe. I can't keep any subsequent children safe. Like, really using some concrete reality testing and going through those distortions with dads, I find to be very helpful. Ghosts in the nursery, right? We know that that's a sort of a common theme when working with perinatal mental health that we focus on. And again, sometimes moms may have heard this, but dad doesn't. And dad also has ghosts in the nursery. So whether it's this loss, we know loss brings up all other losses. So sometimes doing in that psychodynamic work, focusing through that. And then again, I find IPT to be very useful with dads in loss, and it's really looking at who are the current relationships in life, where are the interpersonal conflicts, and how can you both resolve conflicts with, whether it's with partner or with people you feel like you can't talk to, you know, what prevents that? And then kind of doing that modeling or even communication analysis, again, if you're familiar with IPT. So I don't know if I can zoom in here, but this is, if you want to do like a Google at some point for yourself, this losing Thomas and Ella story is really a nice way to understand for yourself what happens for dad in kind of his own words, in a way that I'm not able to share with you. So again, if you want to kind of do a little Googling on your own, that's a nice one to kind of get a sense. So I think I've done some case examples, and I think we have about 15 minutes if I'm not mistaken. Kylie, are you there? I can't tell. I don't know if she's here.
I'm here. I'm here.
So we have
Yeah.
15 minutes.
It's like 15 minutes around, yeah.
So maybe I'll pause here and see if anyone has any questions. And if not, I'm happy to just talk more about some case examples that I've used and maybe some modality that I used to treat it. Anyone have any questions entering in the chat box at all? No questions? I'll give you a second to type. I'll keep the chat box up in case you do have some questions. So let me think about, or if you would type into the chat box, what kind of a case would feel most helpful to hear about? So trauma or like a PTSD case, a bipolar case, what feels like it might be the most useful for you to get a sense of? No? Yes? Okay. Oh, okay. Let's see, we've got one here. Working with the birthing person who wants to speak for the partner. So say a little bit more about that. That was a question from Ellen, because I'm not certain what you are talking about. We're kind of talking specifically today about men and not necessarily trans men who are birthing. I think the hormonal research is a little bit different, and I think the sort of historic trauma is a little bit different. So okay, so you've clarified here. Father not engaging directly, but through women. So are you talking about how might we enlist parents who are maybe not coming to treatment or not navigating treatment? Yes, no? Yes, okay. So how do you kind of get dads to come into treatment at all in general? And again, I think you really have to, it has to be reflected in both the sort of way in which your practice is and then also the kinds of colors that you use and everything from your marketing material, frankly, to how you speak. And I know that feels very, very vague, but I'm a little salty. So if you ever meet me in person or you know me, I'm a little salty. And I have found that, again, when I'm working with dads, being a little bit more salty and more specifically able to tolerate anger is a way that I have found that they are able to come to me in my practice. And I think a lot of that is because I'm speaking in globalizations and generalities here, but in my experience working with some of my female counterparts, men sort of screaming and shouting in their office feels incredibly intimidating and scary. And I think that that's often why, because therapy has been so traditionally female dominated, that there isn't as much interaction with the therapeutic community, because there's just this sort of understanding, I think, that a lot of men may have, that they don't feel safe enough to be their true core self, which is going to have a different expression than it might with a woman. And again, when we think about how much anger is a real manifestation of paternal depression, like how in your practice might you signal or indicate that that is okay, that you are not scared by real intense expressions of anger, right? So I know I recently moved offices maybe about like a year and a half ago. And I see quite a bit of men. I see, like I mentioned, and not just in perinatal, but overall. And I have clients who literally will get up, pace, shout, scream, and like clap their hands. So much so that when I first got there, some clinician down the hall was like, knock, 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 are you okay? And again, I have a very good screening practice that I've developed over time, but I have a very good tolerance level for different kind of expression of emotion. So it's everything from being reflected in, using more neutral language in your advertising and marketing, making sure dads are reflected in your advertising and marketing, and then whatever that looks like to you, signaling somehow that you're going to be able to welcome what might not be what might be expressions of anger. So again, that's not that every dad is angry. I just think it's important to acknowledge that. All right, so moving on here.
You want me to read you some questions?
Yes, so I just figured finish that one. So
the next question's from Carol. It says, my greatest struggle is dads in the days after loss saying, I just need to be strong for her, meaning the partner. How should I respond? I realize this is a role and it's their view of themselves, but I want to help them access what they feel as well.
And you know what, it might not be in those immediate days after loss, right? So I think like with anything, it's validating the feeling and not the fact. I understand how important it is for you to be strong, and I really respect that. And I want to make sure that we can bolster you as well. Because again, if you're telling me how important it is that you provide strength for your partner, you also need to draw strength for somewhere. You have a finite amount of energy and a finite amount of strength, as we all do. So how can I help bolster and support you so that you may do what you feel is best for you and your family? So that might be a way that I would respond. I think in those early days, I wouldn't try to shift somebody from especially if they're articulating, I need to be strong for my partner. You know, it's like, what about that? You know, why is that important to you? And if they don't have access to why it's important to them, because again, they're just kind of in that initial shock, it is, how might I help bolster you, because you have a finite amount of strength, and I want to make sure that we're able to feed that strength for you too.
Thank you. Okay, another question is from Sarah. It said, maybe a case surrounding multiple miscarriages, and you've worked with the father for a while. How do you help them with these multiple losses and having the conversation surrounding adoption, surrogacy, if they still want to have a child, but maybe afraid to admit that they want to go that route?
Okay, so this sounds like kind of a complex case. You know, there's a couple of pieces here. I think I mentioned earlier that I've worked with people who do have protracted experiences in terms of miscarriages. And I think I would focus on sort of like, help me understand ways in which, you know, this has impacted you. What's your level of exhaustion? Do you guys have a point at which you know that you may not want to continue this process? And I don't really put adoption or surrogacy out there unless they bring it up, because even though, of course, and sometimes we all get these counter-transference components where we're like, for God's sake, please, I think that you need extra support, or, you know, still adoption or surrogacy is like such an amazing option. I think it is so much like, how can they bring it up? And I bring myself into the room. So if I am having that kind of a strong countertransference reaction, I will just name that. Hey, you know, I'm having a really strong countertransference reaction, which is that I'm having such immense empathy for this journey that you guys have undergone. And I'm wondering what it feels like to continue to do this. And, you know, to what degree does it feel like this is your only option? So that might be how I would enter into the discussion. Again, just, I know, you know, we all have sort of preferences of how we navigate clients, but that would be how I would enter it. So, you know, that's sort of a general answer to kind of a little bit more of a specific dynamic. And I hope that that was helpful.
Thanks, Elise. Amanda is wondering if you can talk a little bit more about the correlation between the behavioral issues that might come up in children and men's emotional issues.
Well, I think, you know, I'm not a child therapist, so I want to be clear that the answer that you're going to get is really much more about how I would navigate this with a dad after loss, and how I might navigate this at all with the family system. So because we know that that research is there, I will use psychoeducation as a way to make sure that dad understands that he needs treatment. And it doesn't have to look like the kind of treatment that I deem necessary, right? So of course, in my perfect world, most people do sort of like, if it's warranted, psychiatric support as well as therapy, but that's not accessible or preferable for all people. So I try not to hammer anyone over the head with what my preference is, but more so just kind of provide that psychoeducation along the lines of like, hey, here is what we know in the research, and I am bringing this to your attention because I am concerned. Not that I'm trying to fearmonger or intimidate you, but I know how important your health is for the whole family. And maybe you've let me know how much or how important it is for you to support your family, and that you don't have time for therapy or whatnot. But this is a really important way that you might be able to support your family. That if we again can help bolster you and give you a well to draw from, then it will be really great for everybody. I mean, the language right now on the top of my head is a little clunky, but that would be how I would enter it, is psychoeducation with dad. And then in terms of the sort of longer term impact from children, again, I know that these are things that sort of happen, but in terms of how to treat them, how to treat children who have had dads who've kind of suffered some sort of paternal perinatal mental health disorder, that is unfortunately not my specialty. So, but it seems like maybe a good topic to kind of let some of my colleagues know people are interested in.
Okay, and then I think this is our last question. It's a little long, so bear with me. It's from Catherine. She says, I've worked with a couple who had several losses, a set of twins, about 20 weeks gestation, and then a miscarriage around 12 weeks. And then they had a live birth last year. This year, the mom is much older and has eggs that have been fertilized, and she's eager to make a decision about future pregnancies. Her husband has never engaged in treatment. He's a veteran and he has avoided all invitations to it.
So I think how I'm going to make this a little bit more general so that we're not kind of talking specifics about clients, but when I have a treatment reluctant dad, and again, I usually see them after some time period, and they've come in through not just like immediately like, hey, you need help. I really can empathize when you have a partner who's like, I need my husband to do something and he's not doing it. So one way that I navigate that is I usually say, hey, this isn't an invitation. I need information from your partner to help treat you. And can we tell your partner, hey, my therapist needs information from you in order to kind of effectively treat me. And remember, I'm a marriage and family therapist, so I invite everybody in. I'm like, when clients are like, I want to bring my best friend in, I'm like, bring them, and they say, I want to bring sister or mom or dad. I mean, I have clients who I've literally met the whole social support system. And a lot of that is because, look, your client on your couch is kind of giving you one view. And we know, right, there's always like your client's view, maybe their partner's view, and then the actual truth. So I try to get a sense of, how might we support you with all information from your partner? And is that a way that your partner might, one, realize that therapy is not scary, and two, we don't have to talk about anything they don't want to talk about. So that may be a way that I want to handle it. But again, if a partner is completely refusing to engage in treatment, then that becomes the work that I do with my client, if all else has failed, because you don't have control over getting somebody in when they don't want to. But that's my route. I've just given you one way that I navigate it, and then if that fails, it just becomes, okay, the work between myself and the client is what does it feel like to be in this place, and how are you going to navigate it?
Thanks, Elise.
Yeah.
So I think that's all now. And then if you have questions about specific studies that you wanted to know the references for, you can email Elise.
And I'll just go back here to some of, so here's one, it's the MOBA study. And these are ones that you can find on Google Health. Let's see, let's go back. So the MOBA study, and then Ram Chandani has done a lot of work with men. So that's another one to look up. And then I think the ALSPAC study is another one. So ALSPAC study. So those three studies, but again, you know, that's the Avon longitudinal study of parents and children. And you know, you are welcome, of course, to email me for sort of a more detailed bibliography, but those are the three. So ALSPAC, Ranchandani, and the MOBA study.
Well, thank you so much, Elise.
Of course.
And
I
thank you, everybody.
so appreciate everyone having patience with, again, right now during the time of the world. And this is my email, therapy@elisespringer.com, if you'd like to email me. And thanks for having me, Kylie. I so appreciate it.
Thank you. And thank you, everyone, for joining us.